He's gonna talk from Oxford, of course, and he's gonna talk about eosinophilia and the steroid sensitivity in asthma and COPD. Please, Ian.
Thank you very much, and thank you for this invitation. It's a great pleasure to be in Bologna, which of course is the home of the oldest university in the world. This is my institution here, which is the second oldest university in the world. It got its charter from the Pope in 1096, and it only took them 1,000 years to appoint their first professor of respiratory medicine, which is me. I'm going to talk about eosinophilia and steroid sensitivity in asthma and COPD. I have some disclosures. So I thought I'd start by very briefly reviewing how we currently use inhaled corticosteroids and why there is increasing concern about our current management algorithms. Introduce you to eosinophilic airway inflammation as a marker of risk of attacks of airway disease and likely response to corticosteroids. This seems to be irrespective of the label the patient has or the context in which you use steroids. I'm going to talk about clinically accessible biomarkers of eosinophilic airway inflammation that can be used in the clinic and in primary care, and suggest that it is now time for us to adopt a new biomarker-directed approach to the use of corticosteroids in airways disease. Now, we all know the GINA guidelines. This is the latest version. Inhaled steroids are introduced early in asthma. In fact, the 2014 guidelines suggest very early introduction of corticosteroids, and thereafter the dose is increased according to the patient's symptoms and lung function. So the assumption is made that symptoms and lung function reflect a steroid-responsive process. The basis of the use of inhaled steroids in COPD is this study, which is nearly 20 years old. It's a UK study that looked at the effects of high-dose inhaled steroids on the rate of decline in FEV1 over 3 years in about 600 to 700 patients with moderate to severe COPD. This was a negative study, so there was no effect of treatment on the rate of decline in lung function. But one of the unexpected, but interestingly secondary outcomes was that exacerbations of COPD were reduced by 25%. And this has been shown repeatedly in different clinical trials, and is the basis for our use of inhaled corticosteroids in COPD. Because inhaled corticosteroids have a small effect on symptoms and lung function, these cannot be used as a marker of response to treatment. And the GOLD guidelines, and I don't think this has changed, but maybe I'm wrong, suggest that steroids are used in a risk-directed fashion. So if you are at high risk of exacerbations based on your past history or on the presence of significant airflow limitation, we use corticosteroids. So this is a risk-directed strategy. In contrast, dual bronchodilator therapy, which do have significant and measurable effects on symptoms and lung function, it can be titrated on the basis of these measurements, I would suggest. Now, why should we be thinking about changing these paradigms, which are at least 20 years old? Well, first, there's increasing concern about treatment costs, particularly in a nationalised healthcare system such as the UK. So in the last 10 or 20 years, and I think every decade, the costs of treatments for airways disease increases threefold. But in the last decade, in the UK at least, there has been no improvement in key outcomes. So this is hospitalisation rates from asthma. In the decade before this, they reduced markedly, but our progress has stalled. So we are throwing more steroids at the problem, but not seeing further improvement. In COPD, 2 combination products are in the top 5 drug expenses in the UK. And the benefits of triple therapy, so that is the addition of steroids to maximum bronchodilation, is marginal when looked at from a cost per quality point of view. So if you hard-nosed and look at the economics, this is a marginal intervention in relation to other things that we can do in COPD. Secondly, there's increasing recognition of adverse effects of inhaled steroids, and particularly the more potent inhaled steroids that are coming through. This is a paper by Sami Suisa published 2 years ago in Thorax, showing that the risks of pneumonia with use of inhaled steroid are a function of the dose and the duration of steroid use. And in COPD, where the risks seem to be particularly significant, we tend to use high-dose, prolonged treatment. There are also attractive alternative treatment options. We have a number of dual bronchodilators. This important study by Helga Magnusson showed that if you add salmeterol to tiotropium, outcomes in terms of exacerbation over the next year are no different with dual bronchodilator therapy compared to triple therapy with continued inhaled steroids. So these are attractive potential treatment options, but in primary care and secondary care we have no clear guidelines on who should receive dual bronchodilators and who should receive a steroid-containing preparation. But I think the main driver for change for me is that we have new insights into airways disease as a result of new assessment techniques. And I think assessment of eosinophilic airway inflammation using induced sputum has been highly influential, and we should all be very grateful to Freddie Hargreave, who developed this technique in the late 80s, early 90s. We have found, and this was an unexpected finding, that patients with COPD and patients with asthma are largely indistinguishable in terms of their sputum pathology. So I've shown here the induced sputum eosinophil count, and you can see that both groups of patients have a raised induced sputum eosinophil count. And in categorizing our patients into asthma and COPD, we must be aware that we're not identifying discrete pathologies. Moreover, the induced sputum eosinophil count seems to be a clinically useful measure in that it relates very closely to the response to corticosteroids. Here you see in asthma, the higher the sputum eosinophil count, the bigger the improvement in FEV1 after treatment with inhaled or oral steroids. And the same story in COPD. As you increase from the low to the high tertile of induced sputum eosinophil count, you see a more robust response to steroids. If you take things a stage further and ask the question, well, in long-term use of steroids, should we be targeting symptoms or risk, as I've suggested, the guidelines still say, or should we in fact be targeting the pathology? So if the patient has a steroid-responsive eosinophilic pathology, they get treatment. If they don't, they don't. And these are 2 studies that have asked this very simple but important question: is inflammation-guided management or symptom-guided management better? And they both show the same thing. It doesn't matter whether the patient has asthma or COPD. If you assess and target and treat eosinophilic airway inflammation, the risks of asthma and COPD lung attacks is reduced substantially. And what's more, patients who have guideline managed treatment often have persistent eosinophilic airway inflammation, and the main clinical expression of this is an increased risk of exacerbations. Now, that work had relatively little impact, and I think the big reason was that induced sputum is not a technique that can be used in standard clinical practice, and certainly not in non-specialist clinical practice. So a great deal of effort has gone into looking for simpler, more clinically accessible biomarkers. And here we've had striking success. And let's not forget that other organ-based specialties look at us in envy because we have great biomarkers of corticosteroid and biological responses. So I'm going to talk about two, pheno and blood eosinophils, because they're very easy to measure and accessible. Pheno probably has its main role in asthma, which is a very simple airways disease, and in primary care because the method is very easy to do and there's no possibility of measurement error with pheno. Blood eosinophils have been particularly useful and important in COPD. 70% of patients with COPD in the UK have a blood eosinophil count in their medical records. Pheno hasn't been evaluated in COPD much. We've made the assumption smoking will confound the results, but in fact there is very little data. Now, does use of pheno to guide asthma management, and particularly steroid use, result in improved outcomes? These are two meta-analyses that have come to exactly different conclusions on this question, and this is an issue that has not been resolved to the satisfaction of everyone. And one difficulty is that all pheno-guided management algorithms have been imperfect. Please read this paper by Peter Gibson, which is a masterly analysis of all the clinical trials looking at pheno-guided management. But we haven't done the killer clinical trial yet. We've had extraordinary difficulty getting funding for the killer clinical trial. We haven't evaluated utility using optimum cut points. We tend to assess steroid titration across outcomes where there's a flat dose response curve, so we're not going to see anything. The management algorithms have been suboptimal and illogical. In particular, many studies have, because of the ethics committee, not been able to reduce steroids in a symptomatic patient. So the ethics committee, the vicar on the ethics committee, has already made his mind up. So we're never going to make progress until we deal with these issues. And there's no doubt further studies are needed. But I think the best study is this, again done by Peter Gibson's group, looking at the use of pheno to guide asthma management in pregnant women with asthma, and showing very striking results. So a large reduction in the number of exacerbations of asthma that occurred during that pregnancy. And this better outcome was achieved with a significantly lower daily dose of inhaled corticosteroids. And what was particularly compelling about this study is that both patients responded. So not only the mother, whose asthma control was better, but the baby was half as likely to require admission to hospital, to a special care baby unit following birth. And I think that the real value of pheno is in primary care, non-specialist practice. This is an important Dutch study that has looked at the use of pheno in primary care. It's a cluster randomized trial. And the main focus of this trial was cost effectiveness. And if you look here at pheno-guided management, this is the FCA, where the goal of management was to suppress symptoms, but also pheno, resulted in fewer exacerbations, less treatment, and was highly probable to be a cost-effective approach. This has been very influential in the UK, and NICE, which is an organisation whose primary concern is cost-effectiveness, have made a strong recommendation in the UK that FeNO is assessed in primary care as an aid to diagnosis and management of asthma. Now, I'm going to turn now to the blood eosinophil count and data in COPD. This is a phase 3 trial of a once daily and new inhaled steroid, fluticasone furoate. It's a traditional COPD exacerbation study, a large population who were randomized to 3 doses of FF in addition to vilanterol, a once daily LABA. Now, this study showed, as usual, that adding steroids to bronchodilators reduces exacerbations by about 25%. One unexpected and worrying finding of this study was that the higher dose of FF increased death rates from pneumonia, and that was a significant concern for the company. They had measured the baseline blood eosinophil count prior to randomization, and therefore there was an opportunity to look at treatment responses stratified by baseline blood eosinophil. And in this analysis, we have combined all the doses of FF. And what you see in the patients that were randomized to vilanterol alone, the risks of a COPD exacerbation increased progressively with increasing blood eosinophil count. And this is a very consistent finding. So this is a marker of risk. And that the FF, the steroid, all it did was reduce the eosinophil-associated risk. So that was abolished. And the beneficial effects of treatment were particularly obvious in patients with an eosinophilia and were entirely absent, I would suggest, in patients with an eosinophil count below 2% or 150 cells per microliter. This is the group that had a high risk of pneumonia, interestingly. So if you give a potent immunosuppressive drug to a patient group who don't have the relevant pathology, only bad things are going to happen. Whenever I show this data, people say, well, these are clearly patients who've got ACOS, whatever that is. Well, if they've got ACOS, you might struggle to find it because asthma markers like atopy, the absence of smoking, or shown here, bronchodilator response, were not associated with pathology at all. So I don't think this is recognizable ACOS. Now, Guy Bruxelles, I would encourage you to read this editorial, really summarized the data very nicely with this diagram. And in making a decision about use of inhaled steroids in COPD, we should consider benefit and risk, as with any treatment. And in the blood eosinophil count, we have a biomarker that tells us a great deal about both. And perhaps what we should decide is whether the patient lies in area 3, where there's likely to be great benefit and relatively in relation to the risk, or in area 1, where the opposite applies. I'm going to show you 2 more studies where we have data stratified by blood eosinophil count. INSPIRE, which was a trial that compared tiotropium with Seretide. And this was a disappointing study from the point of view of GSK because tiotropium was as good as Seretide for the primary outcome, which was attacks of COPD or COPD exacerbations. The second study we've already looked at, Isolde, another disappointing study because high-dose inhaled FDP didn't reduce the rate of decline in FEV1. We've seen that already. What about if we look by blood eosinophil count? Well, again, in the eosinophil high subgroup, patients who are not receiving an inhaled steroid, so this is tiotropium alone, have a high risk of exacerbations compared to eosinophil low patients. And the serotype reduces quite substantially the risk in eosinophil high, but is in fact, if anything, inferior to tiotropium in the eosinophil low group, although this wasn't significant. Isolde looked at the rate of decline in lung function, and this, at the time, 20 years ago, was the golden grail, the holy grail of management of COPD. Can we modify disease activity? Can we prevent progression? It was a negative study, very disappointing. But if the patients have a raised blood eosinophil count, two things to note. Firstly, they have a rapid decline in lung function compared to the eosinophil low, so they are prone to exacerbations and they have a rapid decline in lung function. And secondly, inhaled steroids work very well at reducing the rate of decline in lung function if the patient has the relevant pathology. But they do nothing if that pathology is absent. So I think this data is compelling in its consistency, and it addresses many concerns with the use of inhaled steroids. And really, Alvar Augusti and I put our heads together and thought, well, what are the implications of this for asthma and COPD? And I think when making treatment decisions, the division between asthma and COPD is largely irrelevant. You have to assess two things. Firstly, do they have symptoms as a result of airflow limitation, in which case bronchodilator therapy is likely to be helpful? And secondly, do they have risk, be it risk of exacerbations or risk of accelerated decline in lung function as a result of eosinophilic airway inflammation, in which case targeted treatment will help? And this approach is a step towards precision medicine in airways disease and would result, I suggest, in more efficient and effective use of highly effective treatments. And it will be particularly important as we enter the biological era for airways disease. One particular importance of this approach is it immediately identifies the patients who have a high unmet need. So what about patients who have symptoms but don't have airflow limitation? I see a huge number of these patients. They predominantly have chronic cough. Most of them get put uneasily in the asthma or the COPD bucket, but they have a very different problem. And shouldn't we be highlighting that and studying it? I also see patients who have exacerbations but no eosinophilic airway inflammation. I would suggest that infection-related neutrophilic airway inflammation is a very important pattern of disease. Steroids are not a logical treatment, but perhaps macrolides are. So biomarkers of eosinophilic airway inflammation identify risk and likely inhaled steroid responsiveness, irrespective of whether that you think the patient's got asthma, COPD, or ACOS, or you've no idea. There's increasing evidence, and I think we're reaching the point where we have to act on this, that biomarker-directed management is a better approach than current guidelines, one-size-fits-all guidelines. So I think our clinical approach needs to change. Thank you very much.
Thank you very much, Ian, and I think we have still 3 minutes for questions. Alberto first.
Thank you, Ian. Very, very nice presentation. I have a couple of questions. One is related to the low eosinophil counts, and I'd like Guy as well to intervene. You said that low eosinophil count is associated with with increased risk of pneumonia, and what is Guy suggesting in the editorial. But I don't know whether the evidence is that strong that low eosinophil counts is associated with increased risk of pneumonia. The other is related to high eosinophil counts in the other 3 studies that you just published on thorax, where it's not that consistent, and also it appears to be associated with decreased risk of, well, increased efficacy also with salmeterol alone. So that I doubt is that a general marker of responsiveness to any treatment, or is ICS driven? Thank you.
So the second point, I think, is a key point, and I thank you for raising it, because that was an unexpected observation that in eosinophil high patients appeared to benefit from salmeterol alone. But of course, we don't have any other data that we can interrogate to validate that finding. And the big study I showed you was looking at the effects of adding ICS to a LABA, and that data is pretty consistent. The second question on eosinophil low and risk of pneumonia, in the Relvar study I showed, the risk in vilanterol alone people who were eosinophil low was twice as high as those who were eosinophil high. So we've looked at all the data that we can get hold of in a meta-analysis, and it now appears that the risk of pneumonia is about 30% higher in people whose blood eosinophil count is below 2%, independent of whether ICS are used or not. Yeah. So it's a relatively small increased risk. Yeah.
Yeah, but it's a novel cancer. I mean, it's not something that is known. Okay.
Yeah, that's not published. You're right. Yeah.
No.
Ian, from your experience with these studies on steroids and on biological, would you advise anyone of any potential concern of reducing eosinophils? Because eventually eosinophils are a defense, it's like neutrophils, and inflammation is also a defensive mechanism. So keeping a person with low eosinophil for a long time, is it associated, in your opinion, with any kind of risk that we could anticipate?
So we've got very little data in COPD yet, but in the asthma, severe asthma studies, I've been surprised how little difficulty has been reported, and many thousands of patients have received treatment with mepolizumab and have depleted their blood eosinophils to very low levels, and we've had no reports of parasite problems, for example, even though treatment has been used in countries where that might be an issue. So that's been a surprise. Now, benralizumab is a different kettle of fish, because this is a drug that targets the IL-5 receptor and depletes eosinophils very completely to a lower level than drugs that target IL-5. And there may be a concern there. And certainly the COPD study that Chris Breitling was the first author, and I think you wrote an editorial, very good editorial, there might have been a concern that the low eosinophil patients were actually getting worse. But all the anti-IL-5s are now being evaluated in big phase 3 trials in COPD, so we will get more information in due course. But I think that is a valid concern. And
if I may, actually, if we are going back to the Jerry-like studies, there is a very nice reviews that he published, let's say something like 6 years ago, showing the data that people can survive without eosinophils. So if you go back to that paper, probably you might have some insights about this issue.
Yeah.
I guess that there are both.
so there are mice studies, Guy was just telling me, that suggest eosinophils are involved in tumor surveillance in colon cancer, I think. Guy, is that right? Yeah. So we have to see, and of course it is possible, and it would be so disappointing, but it is possible that in post-marketing surveillance something emerges.
Yeah.
Yeah.
Very last question.
Thank you, Ian. Thank you, Ian. Very short question. Have you got any data on relationship between the eosinophils, blood eosinophils, and the presence of eosinophils in airways, maybe in induced sputum, in COPD.
Yeah, I'll show you what I've got in the next talk, but,
Okay.
but
Thank you.
the bottom line, I would summarize it as, these are not perfect tests, but what you have in, particularly in COPD, is often access to multiple blood eosinophil counts, and if it's always low, I think that's a significant finding. You also have access to other tests. I use FeNO and blood eosinophils, and I think if all your biomarkers are low, you know, it helps you. And of course, we use sputum, don't we? So we know for sure. But I would say the more you measure and the more often you measure, the better you are able to. Yeah.
So thank you very much, Ian.